Okay, I'm Professor Dhillon. I'm the Program Director for the Postgrad Diploma ENT, which many of you are doing. Those that are not doing the Postgrad Diploma ENT, but say doing family medicine, will find hopefully this lecture quite useful. At least that's the idea. So what I'm going to do is I'm just going to present you with 4, 5, 6 cases, a bit like a bad clinic that you have where you see nothing but ENT cases. So rather than a set piece, which generally bores the pants off everybody, I'm going to go through some clinical cases and we'll go where you go with your answers, basically. So I'm going to do less of the work. I want to engage you and your brain in particular on a series of clinical issues. And when I ask you to respond to the questions, please just tap in your answers, 1 or 2 words or a very short phrase, into the chat box. Okay, so has everybody understood how we're going to work this? Yeah. Okay, let's crack on. Okay, here we are. This is a 30-year-old male who looked in the mirror. Okay, and he noticed this rather large right tonsil, which you can see here. It was bigger than the other side. He's got no other symptoms. He just happened to look in the mouth. So what do you see in the oropharynx besides this large lump? Anything else you can recognize? Obviously, don't tell teeth and tongue because that's pretty obvious. Structures a bit further back. Name some of these structures at the back here that you can see. Name any of these structures. Uvula, okay, that's John. Is that all you can see? What's this bit up here, for example? This bit up here, just above the uvula. Hard palate, and anterior to that will be this will be the soft palate. Sorry, Chris. This will be the soft palate, but more anterior would be the hard palate. So if you stick your finger in your mouth, okay, anterior towards your teeth, your incisor teeth in the upper jaw, it's a hard palate. Further back is the soft palate. Okay, so uvula, I assume, is this. What is this little fold here? And what is this little fold here? The palatoglossal fold, John, is a bit further down. These are called facial or tonsil pillars. They're standing either side of the tonsil, which you would normally find in here. So that's a posterior tonsil or facial pillar, and this is an anterior facial or tonsil pillar. And you can see the anterior one here, and you can't quite see the one here because it's covered by the tonsil. Okay, what's this bit here? This area here. Anybody? Okay, that's the oropharynx, Kate. Not the fauces. These are the fauces here, facial pillars here. This is the posterior oropharynx. So any structure behind the circumvallate papillae, there's these papillae on the tongues, which you might remember from medical school. Anything behind that is the oropharynx. Anything anterior to that is called the oral cavity or mouth. Okay, so oropharynx means the oral bit of the pharynx. And you know there is another bit of the pharynx which is higher up here. What's that called? If you go further up behind the soft palate and upwards, you hit what? What is that area called? Nasopharynx. Very good, Petra. Okay, and the bit of the pharynx that's lower down here, what's that called? When you go further down. Anybody has a guess? What's that bit of the pharynx that's further, which is below the oropharynx? Remember, there are 3 bits to the pharynx: Nasopharynx, oropharynx, and what's the third one? It sits behind quite an important structure. Yeah, Rosie. A laryngopharynx, or sometimes called the hypopharynx. Okay, so the pharynx is quite a large portion of your upper air and food passages. Okay, so how would you, on clinical examination, may be able to determine whether this is a benign or malignant lesion? How do you think you might look at this? Clearly an asymmetry. Patient's worried. How could you determine that? Okay, there you might, if it's ulcerated, okay, there doesn't seem to be any ulceration on there. Feel for other neck lumps. That's good, Ollie, but what do you directly hear? So you look at it, you always inspect things with your eyes, and then what do you do when you do a physical examination? Inspection. That's right, John. You palpate, and you palpate with your index finger, put on a glove, okay, bit like doing a PR to feel a prostate. Okay, in this instance, you're doing a PR of the oropharynx and palpating that tonsil. What are you looking for when you palpate? Yeah, the texture's hard, consistency, yeah, well, it's hard, soft, fixed. Can you easily move it about? Okay, that's right. Is it painful when you do that? Mobility, yep. And usually you would have a comparison on the other side, wouldn't you? So you compare the two sides. So if this patient had some tonsils on that side, which they appear not to have, then you can do an easy comparison. So the appearance and the palpation of this might give you some indication whether it's benign or malignant. And then one of your colleagues mentioned that if you examine the neck, you might find some lumps there, which may indicate potential metastatic disease in the neck. What else can you get the patient to actually physically do here that might give you some indication as to whether this might be benign or malignant? You always get patients to open their mouth and do what? You say ah, or ha, or ah, or ooh, whatever your local language is. Okay, could be IE, depending on your language, okay? So you get them to vocalize, and normally the palate would move symmetrically with the uvula up and down. If you find this is fixed and this bit's moving, then you know something serious may well be going on, okay? So those 2 or 3 things you can do very quickly. Visualization, is it ulcerated? Palpation, hard, soft, uncomfortable, whether it's fixed, and then you do a quick R. Okay. Now you can obviously see this lump in the in here. How can you find out the extent of that lump? What else might you wish to examine and why? I think one of you have already alluded to this, which is the neck, but there is one other thing that you might want to do. You can see the tonsil here, and then you see it here. How can you find out whether this is extending more inferiorly? Nasendoscopy, yep. You do a flexible nasendoscopy. In the old days, you would use laryngeal mirrors and things, okay? I don't think I've used a laryngeal mirror in about 10 or 15 years now, and probably burn the patient if I did use it now. Okay, so a flexible endoscopy through the nose and then looking at this particular area, okay? So what are your concerns? Asymmetry, it's a little bit hard, not particularly fixed. What are you going to do? Yeah, okay. I think I'm going to stop Chris answering the questions because he seems to know all the answers. So Chris, in future, if you could answer after somebody else has answered. Yeah, you almost certainly want to biopsy this. Now, it may be that if you had a bit of an ulcer or something here, you could do this as an outpatient procedure. You just take a cup forceps and you get a biopsy of the ulcer and its edge. Well, would you do imaging first? Whatever the imaging shows you, okay, it's not going to be 100% confirmatory. My feeling here probably would be to go for either a punch biopsy if there was an obvious lesion or ulcer that you could see, and then subject the patient to a biopsy. Supposing you did imaging and it said nothing abnormal seen, I wouldn't trust it. Not if clinically this thing had got larger and it was not quite mobile, okay, and it was uncomfortable. I'm not going to rely on imaging, okay? So I would do a punch biopsy, possibly on a lady. If there was, the trouble with a punch biopsy is that if it looks all relatively normal surface-wise, which bit do you do a punch biopsy on? If there was an ulcer there, then it's easier. So in this instance, what is the likely form of management? What is the likely form of management? Yeah, you do an excision tonsillectomy, then you can slice every little bit of the tonsil, and it may be just a tiny little bit that's actually malignant. Okay, you pick it up. So that's what you would need. I accept there may be a little bit of controversy with regard to imaging, but I'm rather old-fashioned and old. Okay, I don't believe images if they don't concur with my clinical suspicion. I would be very clinically suspicious of something like this. If you had two tonsils and one was slightly larger than the other, that's pretty much going to be normal unless you find something else on clinical examination. Okay, that in that instance, I might do imaging if the patient was really worried, and then reassure them from imaging. But something like this, pretty barn door, complete asymmetry, I would be worried. Okay, so any questions on that? Anybody got any questions? What other symptoms besides a lump like this could this patient be complaining of? Supposing it was malignant, what other symptoms might they come with? How else could this present? Okay, pain on swallowing, that's very good, Gabriella. Odonophagia. So you could have dysphagia, difficulty swallowing. You could have pain on swallowing. They're two slightly different symptoms. Yeah, what else? Supposing I stuck in your tonsil area something the size of half a plum. What else might suffer? Not just it's painful to swallow, difficulty swallowing. What else might suffer? You may get a very good, Kate. You may get a change in sort of, a Boris Johnson type voice, posh people, plum in the mouth type, plum, 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 plum in the tail type voice. Right? Okay. What else? What else you use your throat for? Eating, talking, and breathing. That's right. I mean, it's unlikely unless it's pretty large, but they may have some difficulty breathing. When might they have difficulty breathing in particular? Their partners might complain of this. Yes, Ollie. Yeah, absolutely, John. Yeah. They may never have snored or snored very lightly, a mere purr, but, their snoring has got worse because now this lump is compromising their airway at night. Okay, so they get noisy breathing at night, snoring. Okay. It's amazing how interesting just a little lump like this can be. So ENT isn't just snot, is it? And wax. It's quite interesting. Okay. Kept me interested for a number of years. Okay, any questions on this particular case? Anything else anybody wants to ask? Well, I don't know what the primary diagnosis is, John. My suspicion here, what would be your suspicion? Let me throw this back to you as a group. Yeah, I mean, okay, lymphoma is the biggie. He looks quite young. Nice set of teeth. Okay, lovely set of teeth, so you can guess the age. It's not a kid. It's a young adult, at least. So young adults are unlikely to get squamous cell carcinomas. They're more likely to have something like lymphoma. Okay, so that would be my worry here. Okay. All right, good. Let's move on to the next one. Okay. Who's the gentleman on the left? Anybody? Yeah, Lincoln, Abraham. Yeah, yeah. And what American political party did he belong to? Well, he belonged to the same party as Trump, would you believe? A far cry from somebody who introduced the emancipation of slaves, and we end up with Trump. Okay, so that's one of the reasons why in America you find that vast majority of black people tend to vote for the what is their party? It's not the Democrats. Who are the other ones? What are they called? Somebody help me. The GOP, the Grand Old Party, but what do we normally call them? Anyway, it's the Republicans. Yeah, the vast majority of blacks, for that reason, because of the emancipation, have tended to vote for the Republican Party, although that is now changed. Anyway, that's an aside. A bit of political history and modern political machinations. So, what is wax? He had big ears, Abraham Lincoln. What is wax? It's not dirt, is it? In my Punjabi language, it's called dirt. And I keep telling my relatives it is not dirt. The only dirt the body produces is through its backside, okay? Not through its ears. What is wax? Okay, there's ceruminous glands. John, you only had to answer after somebody else answered. Okay, John, you're right. Cerumen is produced by the ceruminous glands in the external ear canal. So it's cerumen. Anything else? Or is it just pure cerumen? The answer clearly is not purely cerumen. So there must be something else. What else does skin produce elsewhere? What else? Sebum. Yeah, it produces oil. Even the skin of the ear canal. Yep, Kate. So we got cerumen, we got sebum, which is oil. Okay, somebody else said sebum. Chris. Yep. What else is there? We haven't quite finished. Dead skin. Yeah. So the keratinizing squamous epithelium that lines the ear canal and the outer surface of the eardrum desquamates and falls into the ear canal. So we got cerumen, sebum, dead skin. And what else does skin do? Women clearly don't do this. Men do. What other glands do we have in the skin? Because remember, the ear canal is just skin, isn't it? Sweat. That's right, Gabriella, sweat. So that is what wax is. It's a combination of those three or four things all mixed up. So the quantity of cerumen, the quantity of oil, the amount of sweat, and the squames means that the consistency of and the color of each individual's wax is vastly different. Now, you're all over the age of 25, I assume. So by the age of 25, you've probably produced half a truckload of wax. Where's it all gone? It hasn't gone into your brain, has it? It hasn't replaced your brain tissue. So what happens to this wax that's produced? What's the posh word for what's happened to this wax? Okay, it migrates what, to Australia down under? I think you're right, Chris. I think the word you're looking for, anybody else, migration is, I'm only being flippant, don't worry. Where does it migrate? Right, extrudes is a good one. Wafted out. Yeah, it's not quite wafting, not by the hair cells. There are hairs only in the outer part of the ear canal, okay, and waxes produce further medial to that as well. So there's a natural escalator or travelator, as John has said, and that carries everything on top of it. So if you see wax, or mummies and daddies see wax in their children lying in the concha area, they get really het up, don't they, and start picking the wax. You've got to tell them that's normal. That's where it's supposed to come, and it eventually falls out in about 99% of individuals. In private practice, thankfully, I see the 1% where that mechanism does not work very well, and they need specialist opinion to sort it out. Okay, so that is what wax is. That's how it comes out of the ear canal. There's a natural migration or extrusion mechanism. Okay, and remember the ear canal is a cul-de-sac. It's like this. This is your concha, and that's the deep part is where the eardrum is, and it's actually a cul-de-sac. And it's a nice, warm, nice, pleasant, warm place. So what is it liable to? What conditions is it liable to being a nice, warm, comfortable place? Well, Josh, you're right. It could be a fungal infection, but it could be any infection. Okay, otitis externa. The skin of the ear canal or the ear canal is infected. So it could be an infection of the ear canal. It could be bacterial. And it's surprising that we don't have more bacterial infections in the outer ear canal. And the reason for that is what, do you think? Is there any special properties that cerumen has? What are the special properties of cerumen? Yeah, it's it's antibacterial, absolutely. Okay. So wax is very, very useful stuff. Okay, it's essentially designed to be an antibacterial agent. Okay, but as the properties of that wax antibacterial sidal elements disappear, you don't want it hanging around. So evolution, or God, if you're a creationist, has designed the ear so that old wax comes out and new wax is forming with these properties. So there's a continuous turnover. Okay. So we have bacteria in our ear canal all the time. If you kill the bacteria by using, say, antibacterial sidal drops, then you may get super infection. And that's why, Josh, you may sometimes get fungal infections in people who've used antimicrobial drops a lot, or they're immunocompromised. and they're more likely to end up with fungal infections. Okay, so how do you get rid of wax that's not naturally clearing? Okay, this should be an easy one. So if you're in general practice, what do you do? Okay, Farina, in general practice, do you do microsuction? That's very good if you do it. That's certainly one option. You flush it. Okay. Well, okay, flush or irrigation. How many of you actually know how to do this, or do you have a nurse that does it? Because compared to 30 or 40 years ago, when I started in ENT practice, virtually no general practice offers syringing or irrigation. Virtually no. It's a handful. Okay. It's a very special technique. So if you've got wax, you need to direct the water jet posterior and superior, so it goes behind the wax and pushes the wax out. If you aim it dead on, it's going to just land up on the tympanic membrane. So the direction of your water jet is quite important. What's the problem with irrigation if you've got your ear canal and it's got a lot of wax in it? What is the potential problem? Because I see patients who've had their ears syringed locally and say the nurse or the doctor made it 10 times worse. It's now even more blocked and it's painful. Why do you think? Okay, there's a risk of perforation. That's usually if you do a direct hit, Farina. What's the other? Water gets trapped behind the wax, okay, and makes the hearing loss worse. What happens if you drop a lump of wax into a beaker of water? What happens to the wax? Risk of impaction. Okay, not its impact. It float. Okay, it floats. It doesn't always float, Kate, but you're half right. But what's the most important thing? You say it coalesces, not infection. That might happen, Josh. You are right. The wax will absorb the water, and then what happens to the wax? It's like a piece of wood. It becomes it expands. It swells or expands, and that produces total blockage of the ear. That's why the patient says the hearing's worse and it's painful. Now you've got this lump of wax abutting the ear canal, and you know that the ear canal is one of our erogenous zones, but if it's sort of impacted on too heavily, it's actually painful rather than pleasurable. Okay, so that's what would happen. So if you syringe ears, you've got to make sure that you actually, if it's almost occluded, syringing may not work well because you can't get the water to go behind the wax and then push it out. You might just allow the wax to absorb the water, expand, and make things worse. So you be a little bit careful. So syringing, what else? What is the other methods? Microsuction, if you've got the expertise and you've got the correct equipment. Yep, that's possible. Anything else? Wax hook. Okay, direct vision. You might use a Jobson horn or a wax hook. Any other way you might clear wax? Common as muck. Eardrops. Okay, olive oil, hydrogen peroxide, sodium bicarbonate. Okay. And again, all these, you've got to remember, if the ear canal is almost occluded by the wax, that means almost closed, then putting anything that has got a water base or an oil base may make the symptoms worse. You just got to warn the patient because it will expand. So they're good. These drops are good if you got half or 2/3 occlusion, not if it looks completely impacted. That's quite a tricky one. Those patients probably need microsuction. But if you use drops, just warn them that things could get slightly uncomfortable before they get better. And so what drops do you use? We've done evacuation by direct vision. That was microsuction. or if you're really clever, you can use a headlight on a lady. So which oils? Olive oil is bloody messy, isn't it? I don't use olive oil. Hydrogen peroxide, lots of buzzing and fizzing and all this. You can use that. I tend to use sodium bicarbonate. Okay. Now, what is the most important thing that you need to tell the patient about using drops? What is the most important thing? Use them properly. Okay. What's the technique then? I think you mean how do you instill them properly or correctly, Farina? That's good. What's the technique? It's very important you tell them the technique. Otherwise, it's going to be a waste of time and money. Lie on the unaffected side. Pull the ear back, the pinna back, so that opens up the ear canal. You put the drops until they're overflowing, and then you press on the tragus. You know that squiggly bit at the front of your ear canal? You press that like a pump 10-15 times to work the drops into the deep part of the ear canal. And you wait 10 minutes, Farina. I don't think any patient's going to wait 10 minutes. If they wait 2 minutes, it's good. So I normally say wait about 3 or 4 minutes. That means they'll wait about 1 minute if you're lucky. And then put a large bit of cotton wool in their ear, get up. 5 minutes later, they can discard the cotton wool. Okay, so that you have to teach them the technique. It's the same with otitis externa. Okay, so if it's bilateral, they do one ear, then they do the other ear. Okay, and how often are you going to get them to do this? How often are you going to get them to do this? Yeah, I would do at least twice daily, and if they can manage one in the middle, that would be good. So if you say 3, they'll probably do 2. If you say 2, they'll do 1. If you say 1, they'll do 1 every other day if they remember. Okay, they're not going to do themselves any harm if they do more rather than less. Okay, so any questions on installation of ear drops? It's worth spending an extra 30-40 seconds, a minute, instructing them exactly how you do it. And you can actually demonstrate by putting your head on the table and pulling your ear back and demonstrating. Okay, that tends to sear it in their brain. Now, there are a handful of patients who have recurrent wax problems. I'm very happy for you to send them to me to see privately, but it may be that these individuals, once the ear's been cleared, that once or twice a week before they go to bed, you can ask them to instill drops into their ears so that you get a disintegration of the wax and it's more likely to extrude. That may be helpful. Okay, for those that get recurrent wax problems. Otherwise, they're going to have a specialist cleaning them out, which is fine. Some people do once a year, twice a year. Some people have a whole range, a whole cohort of patients who I've been seeing for many years just for that. Okay. In most patients, you can refer to requirements before referring. Is this pointless then? Yeah, well, yeah. I mean, look, I said, I don't know why people make rules. You know, we are bright people. You and I are bright people. We're in the top 1-2% of brightness, IQs, and all the rest of it in the community. Okay, in the population. So, if you see a patient with impacted wax, okay, and you may have tried drops and they've got worse, you've got to send them. There's no point trying 2 weeks of drops if they're in agony. Okay, but generally speaking, as I said, if it's not impacted, or even if it is impacted and you warn them, you could try drops for a week or 2, definitely. Does that make sense? Thanks, Josh. Okay, any other questions on that perennial problem wax? No. Okay. Let's move on to the next one. Okay, so here we are. You got audiograms A, B, D, and E, and you got C, which is a series of tympanograms. Type A, type B, type C, type AS, and type AD. Okay, so the first question is select the normal one. What's the normal audiogram and a normal C? B, A, B, B, B. Everybody says B. Yep, that's the normal one. Up to plus 15 to 20 is normal across the right ear, which is the round red circles, and the left ear, which are the X's. Okay, they're just one on top of the other, just like lovers. Okay, that's normal. Okay. And what about a normal tympanogram? A tympanogram tells us how well the eardrum is moving. So if it's very sucked in, it's going to be stiff. It's very sucked out, it's going to be stiff. But if the pressures on the two sides are exactly the same, the outer ear canal and the middle ear pressure, then the eardrum moves very nicely. Doesn't matter what you do to the pressure on the outside. If you raise this pressure here, it will gradually stiffen up. And then if you reduce the pressure on the outside, it'll come back to normal and stiffen up as it gets sucked out. So the tympanogram is A. Yep, on the extremes of pressures in the ear canal, plus 200 and plus minus 200, the eardrum is either very stiff sucked in or very stiff sucked out. When the pressure is zero, if you like, the two pressures are the same on the two sides, it gets maximum movement. So that is a normal tympanogram. So A, the question to A is, the answers to A is B and type A. What about glue ear or otitis media with a fusion? Okay, select both from C and an audiogram, A, B, D, or E. So we're now looking at a middle ear effusion. E audiogram, Farina. Okay, anybody else? What about the tympanogram? Anybody else? B, tympanogram, yep. Anybody else? B, B tympanogram, okay. B tympanogram. What about the audiograms? E audiogram, Chris, yep. Anybody else? What about the tympanogram, Chris? C, type C, okay. E and types AS, okay. Kate. Couple of more people, please. Anybody else? Please embarrass yourself if necessary. It's a good way of learning. No? People have gone a bit shy. Okay, Pietra, E audiogram and type B. Okay, so the consensus is E audiogram, okay, and a type B tympanogram. Somebody put type C and somebody put type AS. So with a glue ear or middle ear effusion or otitis media with effusion, you're going to get a negative middle ear pressure, and that negative middle ear pressure sucks from the lymph vessels and blood vessels secretion full of protein and water, okay, and that produces a conductive hearing loss because the bones of the middle ear now, instead of moving nicely through air like this, are having to move through water. Have you ever tried moving your arms through water when you swim? You do pretend swimming, it's easy. You go in the water and it's actually quite tough, isn't it? So what you get is a conductive hearing loss. So the bone conduction, which is this line up here with the vertical sticks, is normal. That means your cochlear is normal, but you need an extra 15-20 decibels of intensity to hear through the air. So you get an air bone. That's the bone or cochlear threshold. So you're stimulating the cochlear directly, and that's normal. You know, this plus or minus 15. But when you put sound through the ear canal to go through the ear canal, eardrum, middle ear, brain, you need more intensity. And this gap is called an air bone gap. And if it's a normal bone conduction, which it is in this is known as a conductive hearing loss. So a glue ear, an otitis media will give you a conductive hearing loss. So I think everybody put E. Now, there's a bit of controversy between the tympanograms B, C, and AS. If you look at AS, for example, the middle ear pressure where the eardrum moves very nicely, that's the peak of the tympanogram, is 0. So there's nothing, the eardrum is moving, but it's actually generally stiff at both extremes. And because the middle ear pressure is normal, it's unlikely that this audiogram, this tympanogram, you would see in a glue ear or otitis media with effusion. It's like having a, if you see, it's almost a smaller image of type A being normal. So the middle ear pressure is 0 or near 0, sometimes slightly negative. And so the ear drum is stiff. This is just a general stiffness of the ear drum, and we'll come to why you might get this. You don't generally see this in glue ear. Type C, you might see in glue ear as it's progressing. Gradually, the eardrum is getting stiffer and stiffer, and the middle ear pressure is becoming negative before it becomes completely negative, and you get the flat tympanogram. So I would accept C with some caveats, but ideally what you want to see in middle ear effusions is type B. Does that all make sense to you guys? So you get a flat or type B tympanogram and you get a conductive hearing loss. Does that make sense? Are you happy with that? A quick yes or no. Well, that's nice to know, Farina. Anybody else happy? Okay, Rosie as well. Okay, all right. Well, let's move on to the next question then. Okay, select the correct image of audiology, A, B, etc. for a presbycusis. This is an easy one. Okay, Farina says A audiogram. Anybody else disagree with A audiogram? Rosie A, Ollie B. Oh, sorry, A, that's fine. Kate, yeah, it's A. I mean, this is a high tone ski slope type hearing loss associated with presbycusis. I'm 68 and I'm beginning to get this. Okay, I'm beginning to get this. Sometimes you get a notch at about 7,000. Sometimes you see ski slope and then an upturn as the very high frequencies are slightly observed. But this ski slope is typical of presbycusis. It invariably, the left ear, the X's, and the right ear are lovers, one on top of the other. It's symmetrical, high tone hearing loss on the audiogram. Okay, and if you do the bone conduction in this, the bone conduction is going to be sitting there as a threesome. So all three curves are going to be exactly the same. Okay, see this bone conduction we had over here? That bone conduction, if you did it here, would be sitting, lying intimately with these curves as well. Okay, so this is a sensory neural hearing loss because the bone conduction is affected. That's why it's sensory neural hearing loss associated with presbycusis. Okay, what about D? Audiogram seen in wax impaction and a perforated eardrum. Just the audiogram. What sort of audiogram might you get? Verena, E. Anybody else? Any other takers? E, okay. Petra, Rosie, yep. Anybody else? D. Where's D? Okay. We'll come to D in a moment. E, E again. The consensus seems to be E. Now, you and I know that getting wax in your ears produces a conductive hearing loss. And this is the only audiogram, E, that shows a conductive hearing loss. So it's likely to be E. Okay. A perforated eardrum also means the conductive element, that's the ear canal and eardrum and middle ear with the bones in it, the ossicles, is compromised. So you will tend to get a conductive hearing loss in a perforated eardrum. So the answer to this is E. Now somebody did D. There is a conductive element here. True, because that's the bone conduction, and that's the right ear air conduction, and there's a gap between the bone conduction and the air conduction, this gap here. Okay, this gap here. But there's a notch at 2000 hertz where there's no gap. That's called Carhart's notch. And you tend to see that in E, otosclerosis, where the ossicles are stiffened because the stapes in its oval window is stiff. So the whole system is stiff. But for some reason, the bone conduction is affected primarily, we don't know quite why, at 2000 hertz. So you get this notch in the bone conduction, but either side of that, there's a conductive hearing loss. And the audiogram is type AS. And the reason for that is that although the ossicles are stiff, the pressure in the middle ear, as opposed to the outer ear, is going to be the same as a normal ear, except the stiffness reduces the amount of movement the eardrum has. So a normal ear goes through the paces from very low pressure in the outer ear canal and the middle ear, and you get a peak like this. But when the middle ear pressure is normal but the whole system is stiff, you get a flattened curve like this with a normal middle ear pressure. So an otosclerosis, you get this notch plus a normal middle ear pressure, but a much reduced compliance with almost a flat curve. Okay, this is unlike type B, which we saw in otitis media with effusion. Any questions? All happy? Tawanda, yeah, E, okay. All happy. Okay, let's move to the next one. Okay, this is the patient 6 days after tonsillectomy. Why may they seek a consultation for you or even the hospital? List 3 to 4 reasons of why they might be coming to you in the clinic, in general practice or in the hospital. Okay, might be painful. Have a think, Kate. What nerve supplies the pain? What causes the pain? Which nerve is stimulated for the pain? And so pain is one. Yep, that's good. Severe pain. Anything else? Okay, they may have dysphagia. Yep. Not eating. Eating is less of an issue. They're not going to waste away, but difficulty swallowing, particularly liquids. They can't. Dehydration. If you've ever been dehydrated, it's pretty awful. So difficulty swallowing. Anything else that may bring them? Okay. Karina said they've looked in their mouth and it looks all gooey and horrible. They think it's infected, particularly if it's associated with pain. Okay. They may have problems with talking or phonation. Usually it's not a concern, but it may be, I agree. A bad taste in the mouth, yep. Less of a problem. It's one other reason. Sorry, I'm eating a satsuma because I'm a bit dry. Anybody who's seen these patients may have come across this particular symptom, which they find very confusing. Let me try and help you. I asked one of your colleagues where the severe pain, which nerve provides a severe pain in the tonsil region. Do you know which nerve supplies the tonsil area? Yes, cranial nerve 9, which is the glossopharyngeal nerve. So the glossopharyngeal nerve supplies the glossus, which is the tongue, the back end of the tongue, and it supplies the oropharynx, glossopharyngeal. And the tonsil, as we said earlier on, is in the oropharynx. So the glossopharyngeal nerve is being stimulated and it causes terrible throat pain. What other area does the glossopharyngeal supply, which is not in its actual title, but it does supply? It supplies it supplies the ear, but which bit of the ear? There's a tympanic branch of the glossopharyngeal nerve which supplies the middle ear. So these patients get referred pain from the tonsil, which they think is arising from the ear. So otalgia, or ear pain, is not uncommon in patients post-tonsillectomy. You need to look in the ear just to make sure they don't have something else going on, but invariably they're going to have a normal looking ear canal and ear drum, and this is referred pain. So you need to warn the patient prior to a tonsillectomy that they may get ear pain. Otherwise they think the surgeon has made a real mess up and done something to their ear. Okay, so they're the reasons that people would come. The main reason is pain and looking in their mouth. Okay, so the way to overcome this is to make sure that they take painkillers. So what's the instruction that you give to people in taking painkillers for such the etiology of such pain, or any pain for that matter, any acute pain? What's the specific instruction you need to give them? You give them a packet of painkillers, but what's the specific instruction that very few doctors, I think, actually give, and they should? So you give them a box of pills. What do you tell them to do? Anybody? Take on the times outlined. Take painkillers on time. Yep. I think you're getting there. You've got to tell them that even if you're not in pain, you still take the painkillers. Even if you've got mild pain, take the painkillers, because the worst thing is if you get the breakthrough severe pain, to then get on top of it is very, very difficult. So generally speaking, post-tonsillectomy, you need to give them painkillers for up to 7-8 days. Okay? And they must take it absolutely regularly without fail in order to reduce the pain. Okay? Now, the severe earache you can explain. The painful swallowing is because you've got raw glossopharyngeal nerves being exposed to the movement on swallowing. So that can be explained. It should be reduced with analgesics. The ear pain we've mentioned. What about the look of this tonsil? What do you tell the patient on how it looks? It's healing, yeah. You get this temporary lining, this slough, as it's healing, and that slough will gradually be replaced with normal epithelium over about 10 to 14 days. Okay, if they're in extremis or they coughing up a little bit of blood, then you might need to get them to go to secondary care. It may be infected, but if you do 100 tonsillectomies, you're going to get less than 5% that are infected, maybe only 2 or 3%, if that. And generally, if you think they're infected, there's a slight risk of hemorrhage, in which case it's probably better to get the opinion of your secondary care colleagues, because sometimes you might get a bleed which they don't actually cough up, but when you look you see a blood clot there, and it's always wise to be cautious. In that instance, it's infrequent, very infrequent. You send them to secondary care so they can look after them there. They may need a drip for 48 hours because they're also not eating. Okay, so if you warn the patient, I always do when I do a tonsillectomy, that if you open your mouth, it looks terrible. But that's the way it looks, but it will gradually clear. Okay, and also with this, if you get them to eat small meals often, then the swallowing action and the food tends to clear some of this slough off. Okay, and it actually encourages healing if they have small meals often, not 3 5-course meals a day. Okay, small meals, a bit like the Japanese, grazing all day. That also keeps the jaw moving, so the pterygoid muscles, which are in the base of this tonsil, don't get into spasm and get tense. That keeps them moving as well. So things will improve if they swallow often, little meals or snacks often, and obviously keep hydrated. Any questions? Okay, shall we do one more, or you guys all got to go off? Let me know. Shall we do one more, or shall we sign off? And if we want to sign off, any questions? Let me know in your chat box, please. Okay, Farina has to go. So I think you've had a good hour. Are you happy with what we've done? You have me 3 or 4 times again during the course of your program, and you'll have some of my colleagues as well, which hopefully will make ENT even more interesting than I've made it today, hopefully. Okay. All right, well, good luck, and keep up the work, and encourage your colleagues to enroll with us on ENT or other courses in the future. And take care. So have a good day. Bye. It is being recorded.